Hi everyone, my name is Serena Fitzgerald and I'm the chair of the Early Career Research Forum. I'm based in University College Cork in the School of Nursing and Midwifery, and I'd like to welcome you all to this morning's webinar, which forms part of our ECR Forum webinar series throughout the year. So these are relatively small group events to allow colleagues to share their research and expertise on research topics of interest to our network and to provide a safe space really in a supportive learning environment. Webinars are recorded, as you just saw. Mary has pressed the record button and will be available on the Palliative Hub Professional. They're shared widely, largely they would have a number of views, like significant number of views, and build traction over time, which is very encouraging. And just to note, as Mary said, the session will be recorded, or the session for the discussion part will not be recorded, so it opens the floor to wider discussions. If you'd like to enable captions, you can do so at the bottom of the screen. And if you need help with that, please let us know. In terms of housekeeping, just to keep your audio on mute during the presentations, to rename yourself so that everyone can see your name and potentially where you're from, if you can do an abbreviation of that. Turn your camera off for the presentations when Rachel and Ashleen are talking. And of course, these can come back on again for the discussion Q&A part of the webinar. So the questions will be taken at the end. Feel free to put up your hand, or also as the presentation is going on, if you want to put your questions into the chat, we can read them out afterwards and direct them to our speakers. So without further ado, our two guest speakers today are Rachel and Ashleen. So Dr. Rachel McCauley is a postdoctoral researcher in the School of Nursing, Psychotherapy and Community Health, Dublin City University. She's currently undertaking research as part of the All-Ireland Codicide study in collaboration with Queen's University Belfast. This research is focused on the co-production of decision-making framework for planning the place of end-of-life care for children, young people and their families. She recently received a Young Researcher Award from the Vilcek Family Foundation for Paediatric Palliative Care. She holds a PhD in the School of Medicine, Trinity College Dublin, for a project entitled Mutual Support Between Patients and Family Caregivers in Palliative Care. And Rachel also holds an MSc in Health Psychology and a BSc in Applied Psychology. And also online today, we have Dr. Ashleen Crowe, who completed her undergraduate degree in biochemistry, graduating in 2010, and her career veered in other directions for a time. However, since then, she has returned to her scientific roots and completed her PhD in 2023 at the Centre of Public Health at Queen's University Belfast. Her PhD was a qualitative study in public health and focused on information and communications services for those with a rare disease. She is now working as a research fellow in the School of Nursing and Midwifery at Queen's University Belfast, and she's also on the Codicide project. So welcome to you both, and I'll hand over now for your presentation. Thank you.
Thank you so much, Serena. Thank you so much, everyone, for joining us today. Lovely to see some familiar and some not familiar names. Hopefully you'll all become familiar to us. So this presentation is going to be called Where for a Child's End-of-Life Care, shared decision-making between families and health and social care professionals on the island of Ireland. And as Serena said, it is part of the All-Ireland Codicide study, which is a co-production of a decision-making framework for planning the place of end-of-life care for children, young people and their families on the island of Ireland. And I think it's just important to highlight that this study is funded by the North-South Research Programme. So myself in DCU and Ashleen in Queen's University Belfast are counterparts of one another, kind of taking up each other's roles in the Republic and the North of Ireland. So without further ado, I'll hand over to Ashleen to bring you through the start of the project.
Thanks, Rachel. So I suppose an overview, this study has 5 work streams, and the overall aim is to co-produce with parents and health and social care professionals a decision-making framework. So ultimately the framework is what we're hoping to produce, and this is for planning place of end-of-life care for children with life-limiting conditions on the island of Ireland. So I am going to talk first of all, so a little bit of background. So we all know that children with life-limiting and life-threatening conditions are surviving for longer due to increased treatments, improved treatments, and we know then that there's more need then for palliative care decision-making guidance, and that specifically in regards to looking at the place of end-of-life care, we want to look at how those end-of-life decisions are collaboratively made. So I'm going to talk now about the first work stream. And so this will be our systematic integrative review. So the review question was, what are children, parents, and health and social care professionals' experiences of decision-making regarding the place of end of life for children with life-limiting and life-threatening conditions? So we conducted this review and we searched a number of databases, CINAHL, Medline, MBase, PsycInfo, Maternal Infant Health, and we looked at the Cochrane database as well. Myself and Fiona, Dr. Fiona Hurley, looked at the inclusion and exclusion criteria. We screened the relevant articles, and we used the Whitmore and NAFL integrative review framework to analyze and synthesize the data. So I suppose initially we kind of got about 596 articles, but whittled those down to 11 in the end. So it was unsurprising because we expected that, but it is surprising that there were only 11 articles speaking to this topic. There were 8 of the 9 papers reported data from the parents, and only 1 from the health and social care professionals. So I suppose it's just striking that the health and social care professionals' perspective on this decision making about place of end of life care was really limited. And even more surprising is that there were no studies that discussed the perspective of children directly in regards the place of end of life care in that decision. So most parents did report they were involved in decision making regarding the place of end of life care in these 11 studies. But there were a few studies that reported that the decision was absent, that they still weren't getting the option to make a decision around the place at all. And I would say as well that we got a range of studies internationally, and that plays into that as well. So it wasn't just studies in the UK and Ireland. And what we saw was that there are a range of factors that contribute to decision making. And the parent's preference is often to be at home if care can be provided safely and with support. They want to maintain a sense of normality. They want to allow that sense of control for the family. There was a concern from parents over the potential impact that being on all the settings and what that would have on the siblings. And the rationale for parents selecting hospital was often associated with symptom management. In the one study directly from health and social care professionals, the slides are taking life in the room. There was health and social care professionals reported the instability of patients being a concern, and also what access there actually was to community care services. So I suppose work stream 2, there are 2 parts to this. So this was interviews and focus groups. So interviews with bereaved parents and focus groups with health and social care professionals. So I'm going to talk here about the interviews with the bereaved parents. But I suppose before I jump into that, I would say that I guess I was giving an overview of the fact that, Rachel and I have conducted here a very over almost 2 years now, a big study. It was a lot of moving parts. These 5 work streams, and from that, moving from work stream 1 to work stream 2 didn't happen. I'm sure for those of you here, I'm sure you all know, but it doesn't happen as streamlined as that, does it? We don't go from, we do the review and then we'll move delicately into the next piece. So I would say that while we were conducting the integrative review, we were applying for ethics for these interviews and for the focus groups. And that was kind of how we, kept things moving. So, you're getting that kind of the basis of the study, getting that relevant evidence with the review, but also then preparing for moving forward. I suppose also to say then that these interviews, we had really brilliant support from 2 bereaved parents who were our PPI, And we conducted our pilot interviews with them, and it was really useful. And they gave such brilliant insight into just our process, our questions. And so just to say that that we were involved with them doing that to prepare us for this the highly emotional and challenging topic. So I suppose the aim then of the interview specifically were to describe and explain the factors which influence decision making pertaining specifically to the location of end-of-life care of a child. And this was respect to the parents' experiences in different settings, so looking at home, hospital, and hospice. So I suppose we know the background again is that policymakers have been recommended that end-of-life care is improved in all settings, home, hospital, and hospice, because they're different to different families. They're desirable to different families for different reasons at different times. Further direction is needed in regards how to initiate the advanced care discussions, and there are challenges between the differences maybe between parents and health and social care professionals' care goals, and a lack of shared decision-making guidance. And so that's why we this study is so important, and we hope to address that gap. So we interviewed between myself and Rachel and actually 2 other colleagues, and we interviewed 20 parents of 15 children. Our inclusion criteria was that the child had to have died within 4 years of us recruiting the parents. It was to ensure that we were getting that recent perspective, particularly in this case. And there were 14 mothers or female parental guardians and 6 fathers or male parental guardians. We had a range of settings where the children had died, which was home, hospital, and hospice. And I would say we only had the experience of 2 children who had died in hospice. So that was we struggled to recruit parents from that location, but we still were able to get really the data that the parents provided us was phenomenal. Like, the parents were so willing and so wanted to tell their experience. So the range of ages of children were from a neonate up to 16 years old, and we had a range of conditions represented as well. So the 4 themes were familiarity and freedom of home, safety and security of hospital, homeliness and support of hospice, and the child first and foremost. So these are preliminary findings, I should say as well. So the familiarity and freedom of home. So factors that led parents to decide that they wanted to be home were things like they wanted parental autonomy over the care of their child. They wanted the family to feel at ease in their home environment. They wanted protected family time, and they also really wanted the child to be comfortable in their own surroundings. Inhibiting factors that inhibited parents being able to choose to be at home were the onus of care on the parents. That was going to be a significant effort to provide that care, and there could be uncertainty around the support that would be available in the community. Information and support for parents was required, so parents actually needed to know what was possible at home, and that often inhibited parents from being able to choose to be at home. There was the concern over the potential distress to siblings of the child having their end-of-life care at home, and the child's medical needs or instability also led to them not being able to be at home, where if there's a sudden deterioration in the child, it wasn't the option to go home. So just some quotes then. So in regards to potential sibling distress, I was worried about traumatizing the sibling. It's a lot. We didn't have a big house, and we were Scotch. We were saving for this house, and we just weren't in a position to bring her home. So in regards to information and support, so the health social care professional said, do you understand it'll be a huge undertaking for you to have your daughter at home? Not saying you can't have her at home, it's not the right thing. I just want to give you the full picture. And you'll not have a nurse with you 24/7. You will be left or not left, but you'll be doing the majority of this on your own. And that mother in that case was grateful for the honesty there. And then the family being at ease. So I'd say that the home surroundings, unless they're in savage pain, the home surroundings, that's the ideal thing. It gives you peace of mind too. There's familiar things, familiar smells. So then in regards to safety and security of hospital, there the established relationships with hotels and social care professionals facilitated parents feeling like it was a good choice to have the end of life care of their child in hospital. They knew there'd be multidisciplinary supports in practice, that parents be able to care for their other children and provide their own self-care, with medical care being taken over by the professionals. But also a factor that contributed to them choosing to be at hospital was that they were already there, and that there had been a sudden deterioration of the child. Inhibiting factors then to choosing to be at hospital were that it was an unfamiliar or distressing setting for the child. There was a lack of home comforts, a lack of privacy. There wasn't accommodation for the parents or the other family, and that there were issues actually just traveling to the hospital. Distance from their other children was also a consideration. So some quotes then, so distance from other children. So just that was the hardest part for me. Even coming up to the end, I was missing out on the other two children. I felt like I didn't spend as much time with the child who's ill. I would have done things a bit differently if I could go back. Established relationships with professionals. So many of the doctors, nurses, the cleaning staff, just literally every single person that has to do with the hospital knew daughter, and they knew her very well. We wanted an open policy. We wanted her end of life in hospital, and it was beautiful. It ended up being really beautiful. And then just that they're already in hospital, so just sudden deterioration. So we ended up in the situation where we sort of were planning end of life care, but we had another instance of needing emergency care, and it just sort of got rushed, and then that just ended up for us happening in hospital. So in regards to homeless and supportive hospice, parents felt that the hospice, they had opportunity for respite, that the family could be present, wider family, that it was comfortable, less medical, and the child often, if they chose to be at hospice, the child actually did know hospice. They'd maybe used hospice for respite, and that there was always immediate support there when needed. And in regards to the inhibiting factors for hospice were geographical access. So I think even though we had only a limited number of interviews where parents had chosen to have the end of life care of a child at hospice, was due to that, we have limited hospice for children across the island of Ireland, and that means that geographical access is a problem. For some children, again, if they hadn't been using hospice for respite, then it was an unfamiliar environment, in spite of the comforts that were well recognized. And there was also maybe at times a lack of awareness of what hospice resources were available to families, and what support was available from hospice. So in regards to child knows hospice and is known, so everybody knew them, everybody knew him, and they knew him, and it was the idea of this environment that apart from being at home, this is where this child was most comfortable. I think at the end of his life, he deserved to have his family around him. He deserved to have people, those nurses that he knew by name, and I just think he deserved that. And that it was comfortable but less medical. So hospital was very medical. The hospice was completely different, and that's why I thought I'll do the advanced care plans of the hospice, because they would take the daughter as a person and us as a family, and not as medical, if that makes sense. And then it's just unfamiliar to the child. So just there was a hospice, and daughter was just never a fan of it. They were always offering their services more than willing, but again, the daughter wasn't seeing them enough for her to feel comfortable there. And so finally, just the child first and foremost. So I suppose just that all of these factors played into the parents' choice over where the end of life care of their child should be, but the child's wishes definitely had a very strong impact on the parents' decision, and what the child's experience was in different settings. The emotional turmoil for parents in the situation was just beyond anything. It was so difficult, and they were trying to balance so many things, and still ultimately just trying to make the decisions that were best for their child. So just some quotes around that. So just the child's wishes. So I asked Chelsea what did he want to do. He said he wanted to go home. It was always about home for them. In regards to child's experience, the different settings, son he really didn't like hospitals. He was scared. It's not a comforting environment. People coming in, lights on. It's just not set up for comfort. It's set up you'd go in and get your treatment. And just the emotional turmoil, going to your daughter and thinking, you want me to make that decision. There's 1,000,010 thoughts going through your mind. You just don't know. And even afterwards, it's an unnatural thing. It's a thing I can't forgive myself for doing. You're not supposed to make those decisions. And then just that trying to make a decision that was best for the child. So we discussed the options and we came to a decision. So we didn't want to go down the ICU route. We just wanted to make her comfortable. So I suppose just the kind of key thoughts from this were that the family unit, including the child, siblings, and the parents, is considered with reference to every setting. So the family unit, the child, the siblings were considered in reference to home, hospital, and hospice. Information was crucial to the family. So the information prepared families for the realities of end-of-life care at home. Information made families aware of what hospice and services were available to them. And information also prepared parents for what the possibility of death in hospital would be like if there was a sudden deterioration. And otherwise, if they didn't receive that information, they weren't prepared for that, then they felt like they had a lack of choice and that choice had been removed from them. I suppose established relationships with the parent and with staff were also really important, particularly in regards to choosing to be at hospice or hospital. And it made hospice and hospital good choices of place for the child's end of life care, where home was not first choice or not suitable in that case. This was just, and then just hospice could be a home away from home, and hospital could be a place where the child would feel safe. So just, yeah, thanks so much. And yeah, Rachel, if you wanna, thanks for taking over.
Thank you. So then this was the second part of work stream 2. So this work stream was really qualitative, based on interview and focus group data. And obviously we had the two sides of the coin. So we had the bereaved parents interviews, which understandably took the one-to-one format because of the high level of disclosure taking place there. But we felt that with health and social care professionals, because of this multidisciplinary group that was looking after the family, that it would be best if we did focus groups. So yes, the aim of workstream 2B was to describe and explain the factors which influence the decision-making process pertaining to the location of care for end-of-life care for a child with respect to the health and social care professional experiences of end-of-life care in different settings. So just some background to this. Professionals working in paediatric palliative care report distress and powerlessness, both over themselves and their ability to be stoic and emotionally neutral, but also over the child's deterioration and the total lack of control that anyone has over a child's palliative trajectory. And previous research has identified that these professionals report hesitancy around delivering paediatric palliative care due to a lack of perceived preparedness, both emotional preparedness and practical preparedness of how to actually have those conversations. And professionals continue to report feelings of overwhelm, unpreparedness, and anxiety pertaining to the delivery of palliative care principles. It's just how to act around parents, when to deliver information, particularly in relation to the end of life decision making, which often deviates from the advanced care plan. So the best laid plans are set, and generally things will deviate. So despite these barriers, health and social care professionals are required to be stoic and rational sources of information and advice for parents and children attempting to make considered decisions at the end of life. Despite their rapport built up with the family and their emotional investment into these families, they're still expected to be kind of unbiased scaffolding to these decisions. We know that increased confidence of professionals contributes to improved end-of-life care for children and families, but their experiences and perceptions of providing support are largely underreported. So how do we improve what we don't know about? So we had 3 virtual multidisciplinary focus groups with health and social care professionals, and we held 2 in the Republic of Ireland with 9 participants overall, and 1 in the north of Ireland with 8 participants overall. And we included such roles such as pediatric palliative care consultants, social workers, play therapists, specialist palliative care nurses, inpatient and community workers of all types. We tried to kind of mirror the Cecily Saunders idea of total pain. So we tried to encourage people that were responsible for physical, social, psychological, and spiritual pain, so that we could really cover all bases. And then collaborative thematic analysis of the anonymized data took place across DCU and QUB. So myself and Ashleen took the transcripts of anonymized transcripts of our interviews, and we analyzed them collaboratively so that there was no bias for me on my focus groups or Ashleen on her focus groups. We had were able to see them with fresh eyes of each other's focus groups. So the preliminary findings of this work stream were that health and social care professionals reporting the following factors as intrinsic to being assistive in decision-making processes. So the establishment of trust with families, meeting families' expectations, clear communication both between teams and with families, availability of staff with palliative care training, and collaboration between teams. So firstly, the establishment of trust. So professionals believed that fostering relationships with families was to be of utmost importance to establish true preferences for care. And they felt that there was a wall to break down with families to be able to sufficiently understand what type of family this was. And then once that was established, professionals were able to intuit what the family would do when families were in total crisis, to say, okay, I know what decisions you make when you're not in crisis, and I know how you make decisions when not in crisis. I will try and facilitate these type of decisions with you. So professionals were to act as a sounding board for parents to establish and gather information on all options. And really what came through very strongly was the professionals said that they strove to empower parents and advocate for parent preferences. They were rarely advocating for their own preferences. So this professional says, I would have a good relationship with the families that I spent time building that up. That's how you build trust, and that's how you build a therapeutic relationship with a family. And that is how they trust you. They will ask you the questions they're afraid to ask everybody else. And it is so important to get to this stage with the family to be able to assess them in a very realistic way of what they actually want. Then we have meeting families' expectations. So professionals perceived themselves to meet families' expectations, even when the final decisions were not medically advised. So it wasn't the professional's optimal care choice for the child, but in order to advocate for what the parents and the children actually wanted, professionals had to go outside of what they would recommend as long as it was safe. So they also attempted to manage expectations, such as what will caring for a child at home actually look like? It's not going to be the media portrayal of a child at home. Your house is going to be messy, you will have no time for self-care, etc. There will be reduced support than in an inpatient setting, for example. So then to give families all possible options and as much as autonomy as possible, to regularly go above and beyond their formal duties to meet families' expectations. And this was something that health and social care professionals regularly talked about, this vocational aspect of their job. They felt that they were really going outside the remit of their formal duties. And then lastly, to be prepared, to be unprepared, to be ready for plans to respond to changes of mind or the child's condition. So this professional says, everyone has experience from a family saying, we just want to go home. And it's a human desire, but it's not always a logical thing. But the goal is that we don't always wrap the family up, but that we empower them, but do so safely. So they feel that there's scaffolding supporting the situation. Next, we have clear communication, and this was with respect to both communication between professionals and professionals and families. So professionals reported that meticulousness and sensitivity was required in all communications with families, managing hope and expectations in families with unrealistic optimism. So really stating and restating potentially distressing information to ensure that it is truly heard. And we all know, working in palliative care, that this magical thinking can come into play. And it was just about managing that kind of unrealistic thinking. And then having the courage to introduce the idea of end of life as early as possible. And there was this idea of bursting a family's bubble when introducing palliative care. But if bursting the bubble meant that there was more time to plan, so that the child did actually pass away and receive their end of life care in their preferred location, then it would be worth it. So this professional states, if you are not truly listening, connecting with the family, and if you're doing all the talking, you should be saying, what's the most important thing to you? Is it an extra few weeks? As professionals and in an acute setting, you are an authority figure. So stop talking and listen far more. Then we have availability of staff with palliative care training. So staff, the professionals that took place in this study stated that there was huge overcapacity, which resulted in distress in communications for parents. Professionals knew that they did not have enough time to explain something as sensitively as they wanted to, or with as much time for aftercare as they wanted to. So parents were left in information blackouts with no specific point of contact. So when professionals would hand over to a team, they would have parents coming back to them saying, I have no idea who I'm supposed to be contacting on this team. There was huge reliance on the goodwill of professionals to go outside of their formal responsibilities to ensure that there was continuity of care. And there was need for increased degree of palliative care principles in all specializations. particularly in hospital with generalist pediatric staff. So also access to services was dependent on a child's condition, age, and geographical location. So professionals felt that there wasn't equity of care for all. So this professional says what we could do more of is a bit more training for our staff. So then more people feel comfortable and aren't afraid. I can see some situations where certain rooms might be voided because I don't know what to say or to hold that space. Lastly, we have collaboration between teams. So professionals felt that there was need for sufficient and meticulous collaboration and handover, particularly with regards to prognosis of a child. So no surprises. So often there was issues when certain health and social care professionals assumed that the parents already had the full picture of the child's prognosis, and kind of spoke about it more casually than they would have if they had known that they were actually breaking that news to parents. So there can also be discordance in the aims of teams, which can cause distress in parents. So there needs to be need for all teams to be on the same page and, on the same note, delivering the same message to families to avoid false hope or overpromising. So teams need to decide amongst themselves, what is the message that we're saying? Are we saying that there is potentially more time, that the child can potentially go home, when everyone knows that that is actually not practical? And then lastly, coordinating visitation of families so as not to overwhelm them. So if a child has just undergone a physical therapy or had bloods taken and was distressed, for example, we would leave the visitation of that second team for the child to kind of de-escalate that distress. So one of the biggest challenges is the number of services involved. It's coordinating all of those people and making sure that there's good communication between all of the teams involved. It can be overwhelming for families, I think. So there should be a little panel here on the side that says key learnings, if you're wondering what that gap is, just a technological issue. But so key learnings from this work stream: despite their constraints and overcapacity, professionals state that they do strive to meet the high expectations of families. And in order to achieve this, communications between professionals and professionals and families must be meticulous, sensitive, and recorded. Families can lose trust in professionals when not receiving consistent or sensitively delivered information. So there's further training needed here in palliative care principles. Professionals are aware that they must overcome their own personal biases and fears, particularly when they have developed a strong rapport with the family and they are personally afraid of what will happen if the child goes home, for example, to ensure that each family is being treated with autonomy and equity. Open and honest communications and the time in which to have them are perceived by professionals as essential components of rapport building and improved decision making, and really kind of facilitate that intuitive care that is so valuable when helping in decision making. So our work stream 3, then, we took all of the components that we had collected up to this date. So the word work stream, it was like streams of information leading into this big river, that was ultimately going to become our framework development. So all of these learnings were kind of like snowballing to increase our learnings for each work stream. So the integrative review, the information collected from the bereaved parents interviews, and the information collected in the focus groups were all collated to form the statements for this Delphi study. And for anyone that doesn't know what a Delphi study is, it's a survey that is aimed specifically at experts in the field. And from our perspective, experts were not just health and social care professionals. While we did have some fantastic people that took part, policymakers, pediatric palliative care consultants, play therapists, music therapists, all this huge range of disciplines, we also felt that parents were experts. And so we included kind of a split between parents and health and social care professionals in our Delphi survey. So the aim of a Delphi survey is to arrive at a group consensus. So here we have the categories that we included. So we had statements that fell under anticipatory planning, making decisions about place of end-of-life care, including children in decision-making, preparing parents for decision-making, support services, continuing contact and evaluation, and lastly, factors impacting decisions about home as place of end-of-life care for children. So this is what the Delphi looked like. And as you can see, we used a 5-point Likert scale from strongly disagree to strongly agree. We felt that we could include agree and strongly agree as consensus with the statement. And we only included, so we had 3 rounds, and in each round we removed statements that did not receive above 80% consensus. So a consensus again, agree or strongly agree. So after our 3 rounds, we had whittled the survey down to a series of statements that there was full consensus on, everyone agreed with. And as you can see here, we sent out these individual reports. So we showed in this empty column here, the participant score, and then we showed it in comparison to the average group score. But the average group score, while indicative of kind of what the general consensus was, we also included the range of scores because as you can see, for example, towards the bottom there, some of the statements had 4 to 5. So people only agreed or strongly agreed. And it was important to show this to say, no one disagreed with the statement. Everyone agreed, in it, whether strongly or just agreed. But then you have a point, the second point there, that ranged from 1 to 5. So some participants strongly agreed with the statement. So these were the more kind of controversial statements. And it was just important for participants to actually see that data as well as the average. So even just in terms of how you report back to participants, we have to be careful not just to include the average every time, even though it's very tempting. So again, for the workstream 4 then, when we had collated all of those Delphi statements and we had a list of statements that everyone definitely agreed with, there was consensus of above 80% on all of these statements. We collected the 3 work streams that had gone before, and we had a framework development workshop with experts in the field. We had parent representatives at this workshop as well. But because of the kind of the nature of the workshop was to develop this framework, so we needed people that had worked with frameworks for people that work in policy, people that work in all different settings for where pediatric palliative care is delivered, and that would be using these in their reporting systems every day. So we really wanted the user feedback because we wanted to know, how do we make this usable? Do healthcare professionals, what would be most helpful to them? Do they want a checklist? Do they want another form that they're going to have to put in a patient's chart? Or do they just want some sort of scaffolding that will improve preparedness? So we took all of their feedback and we tried to, along with all of our information that we've gathered, and we tried to develop a framework, which is the stage that we're at now. So as we said, we have our integrative review done, our parents' reviews, interviews and focus groups done, Delphi survey done, and our decision-making framework workshop done. So we our steps this far is that we've collated the data from the interviews and focus groups to develop the consensus statements for the Delphi, and then this Delphi survey data was collated and discussed at the framework development workshop with the expert panel, in addition to some presentations based on the workstream 2 and workstream 1 data. And the framework development is currently underway with the second online workshop to gauge the success of the development to be planned. So we do have a draft framework developed between myself and Ashleen, and we are currently just sharing it amongst our team for final approval. Then we will bring that workshop, that framework, to an online workshop with a panel of experts, and we can just gauge the feasibility of it then, and how usable it will be to pediatric palliative care staff. If anybody would like to be involved in that online workshop, please let us know. We will be looking for participants very soon. And that's basically the stage we're at now. So it's been a wonderful and fascinating project. And as Ashleen said, the results that we have gleaned, particularly from the bereaved parents interviews and the focus groups, have just been so rich. The data has been so rich and so fascinating. So I'd just like to say thank you to our entire team in DCU, in QUB, our international advisor, Professor Jane Price, who is in London, And thank you to our funders, the North-South Research Programme. And I would especially like to thank all of our collaborators who have made the process of recruitment, both themselves and bereaved parents, just a wonderful experience. So the AIIHPC, thank you so much. Irish Hospice Foundation, Children's Health Ireland, Laura Lynn, Jack and Jill, Northern Ireland Children's Hospice, Royal Belfast Hospital for Sick Children, Belfast Health and Social Care Trust, Western Health and Social Care Trust, and our parent representatives in ROI and NI. If you'd like to find out more about the project, we are on the Palliative Care Hub.